And so today, really, I'm gonna, the last talk we talked about evaluation for left ventricular function and size. And so today I wanted to focus mainly on the right ventricle, and then also delve into DVT studies as well. Both of those could be assessed, at the bedside in a fairly quick setting, but like with LV function, we really are just looking at big picture ideas. We're not evaluating very subtle findings, but we'll still delve into everything. And then obviously, if there's any questions that you guys have, please feel free to message in the chat or just speak up in the talk as well. So just starting off with the right ventricle. So really, it's going to be best evaluated in the four-chamber or subcostal or apical view. In terms of the subcostal view, we tend to favor that if we're evaluating specifically the RV free wall. And this could be important if we're measuring wall thickness. If we're concerned about a chronic process that has caused RV dilation, you would expect RV hypertrophy. And so in that case, the free wall would be thicker than normal. In terms of what's a normal size of the right ventricle, you do in general want to measure it in two separate spots. So you want to get very close to the tricuspid valve, and at that basal diameter of the right ventricle, it should be less than 41 millimeters. And then you want to measure it halfway towards the apex, so mid diameter, and that's going to be less than 35 millimeters. If we're really only able to get
Rothman, I'm so sorry to interrupt. We couldn't see the slides. Sorry.
Oh, you still can't?
I can see evaluation of the right ventricle now.
Oh, okay. Hold on. Let's see. Yeah, this is it, right? Yeah.
Yeah.
Okay. And then, so when we're looking at the parasternal long view, it's going to be a little bit smaller. So it's only going to be 2 to 3 centimeters. And then if you're worried about RV hypertrophy, the cutoff value for measuring the thickness is going to be 5 millimeters. So if it's more than 5 millimeters, that's concerning for RV hypertrophy. So some of the main signs that we look for if we're concerned about RV dilation. So again, we're quantifying RV size in 4 ways. So it's either going to be normal, mildly enlarged, moderately enlarged, or severely enlarged. And so normal dimensions, the right ventricle should be definitely smaller than left ventricle, and really it should be less than 2/3 the size. If it's mildly enlarged, it's going to be a little bit bigger than that, but still smaller than the left ventricle. So somewhere in between 66% to 100% of the LV. For moderate enlargement, the RV should be equal in size. And then for severe enlargement, that's when the RV is actually going to appear larger. And really, why do we care about assessing RV size and function? Like, what are some of the main clinical applications where that's important?
PEs.
Absolutely. So if we're trying to quantify PEs for sure, if we're assessing the RV strain, excellent. And then in terms of why is that important for PE stratification?
Change management.
Yeah.
For submassive PE or massive PE, I guess.
Absolutely. So, I think one of the main charts that we use, especially in the pulmonary and critical care service, is the chart right here. And this is from the European classification system for PEs. And really, we tend to get consulted or consider PERT activation or PE response team activation anytime we reach that sort of intermediate high to high risk PE. And so how do we risk stratify intermediate low versus intermediate risk high? So all of these patients would have a normal or elevated PESI score. So we're already going to be somewhat concerned about their mortality and morbidity risk. And then, we have to rely on both the cardiac biomarkers and how the right ventricle looks on echo or CT to really decide, is this something that we need to do a more aggressive therapy for or not? So for intermediate low risk PE, they'll just have the elevated PESI score, but they may only have an elevated troponin, but usually the RV will look okay on echo. But for the intermediate high risk PE, they'll have both an elevated cardiac biomarker, and really that's an elevated troponin level, and presence of RV dysfunction on echo or CT. We tend to, it's on CTH, you'll find that it's fairly common finding that the right ventricle will appear enlarged or have signs of RV strain. And then when they do the formal echo, the RV actually looks normal. So we generally prefer a bedside study if it can be done to better risk stratify these patients, especially when formal echo may not be available, over the weekend or at night. So I just wanted to run through some quick examples of clips of 4-chamber views looking at the right ventricle. So this first clip would just be an example of a normal looking right ventricle. And this is the reality of 4-chamber views where you can't actually get the greatest views of the heart. But that being said, you can kind of imagine that the free wall of the right ventricle is over here. And really, it looks almost triangular in shape compared to the left ventricle, and it should be 2/3 the size or less. Another important tell to keep in mind is, especially when we're looking at an apical view, the left ventricle should be the only thing in the apex of the heart. So even if this sliver of the right ventricle looks small, but if it creeps up into the apex, that's abnormal, and that would suggest RV dilation or RV enlargement. And now we're getting to slightly larger examples of the right ventricle. So in this view, instead of it being 2/3 the size, if you compare the right ventricle at top, right, we have the liver here, right ventricle, and then left ventricle down here. And this would be a good subcostal view of the ventricles. You can kind of see that the right ventricle is bigger than 2/3, but maybe a little bit less than equal in size, or perhaps equal in size. This is something where we would be concerned that the RV is mildly enlarged. Then when you get into even bigger or more abnormal findings, you can really appreciate that the RV looks abnormal. In this view, right, you can appreciate that the left ventricle has thickened walls, right, like it normally would, because it's dealing with much higher pressures than the right ventricle. And that being said, the chamber size, the right ventricle chamber size is definitely larger than the left ventricle. The diameter is probably equal to maybe very slightly enlarged. And then you can also appreciate that the right ventricle is heading up towards the apex. So these are all tells that there's at least moderate enlargement of the right ventricle. And stop me if something doesn't make sense or you can't really make out what we're talking about, okay? And then the other main thing in this view that you should also be conscious of is looking at the atria as well. And you can really appreciate that the right atrium is also larger than the left atrium. So this is right-sided enlargement of both the ventricle and the atrium. And then this is going to be one of the more extreme examples, right? So this would be a severely enlarged right ventricle. And again, this is going to be your subcostal view. You have a little sliver of liver at the top. And then, what's closest to the liver and abdomen when you look up towards the heart, it's the right ventricle. And so that's why the right ventricle is going to be closest to the probe, the most superficial to your screen. And then so you have your large right ventricle here, and then you have your left ventricle here. You can kind of make out the mitral valve and then a piece of the left atrium. It's probably a little off axis. That's why it looks very abnormal. And then you have a right atrium here. And again, the right atrium looks very enlarged as well. The other thing I would point out as well is look at the septal wall. Anytime you see it bowing into the left ventricle abnormally, right? So the left ventricle normally should be dealing with much higher pressures. So the septum should be bulging out towards the right ventricle. So anytime it's bulging towards the left ventricle, that's definitely concerning for RV dysfunction. So this is someone that if there was a PE, we would definitely be activating PERT and considering advanced therapies like catheter-directed thrombolysis, surgical embolectomy, TPA, et cetera. So other signs of assessing RV dysfunction or pressure overload. So the classic sign that we look to, and we'll have some examples coming up, is the septal flattening or D sign. This is best appreciated in our parasternal short axis view when normally you have the left ventricle, it looks almost like a donut shape in the center of your screen. And then the right ventricle will be to around like 10 or 11 o'clock to the top left corner and almost look like a crescent shape. So when there's RV pressure overload, instead of a crescent shape, it might look more like a half circle or even larger. And that donut shape of the left ventricle will be, the septum will be pushed in towards the left ventricle. And so you sort of will get like an inverted D appearance of the left ventricle. And so that would be an example where the septum is bulging into the left ventricle. Other signs, anytime the right ventricle appears large or larger than the left ventricle, that's probably already a sign that there's pressure overload. And then we have the more advanced echo signs, which we'll go over, the McConnell sign, and then TAPSE, which is a more advanced scale, which we don't necessarily do at the bedside, but can be done readily. And we'll have some examples of that as well. So this is the McConnell sign. And what is McConnell sign? So McConnell sign is defined as their RV free wall hypokinesis. So the lateral aspect of the right ventricle is not moving well. With relative apical sparing. So what you get is you get the appearance that the RV apex is moving more than the rest of the heart, but the RV apex is actually moving normally. It's just that the rest of the right ventricle is not moving. And so really what you see is the apex moving up and down, almost as if someone's jumping on a trampoline. So if you can just imagine someone, standing on the apex here, going in and out. So that's an abnormal signing. That's very specific for RV dysfunction. It doesn't necessarily delineate what's causing the RV dysfunction and whether it's an acute or chronic process, but it does show that there's at least some signs of RV dysfunction. Question about that? Does everyone see that? So apical sparing with decreased movement of the lateral free wall.
Does that mean that the apex is functioning, or it's moving because of the left side?
It's largely moving because of the left side, yeah. And so it looks like it's getting pulled back and forth, yeah.
Yeah, I got mixed up with that question on the quiz because I felt like it meant that the apex of the right ventricle was functional, but it's still all relatively hypokinetic.
Yeah, everything is if you in terms of like the wall structures, right? So the free wall is not moving, the RV apex is still moving, but again, it's mainly because of the movement of the left ventricle. Yeah. And then in terms of the TAPSE, so what does TAPSE stand for? It's pretty long, that's why we just call it TAPSE. So TAPSE is tricuspid annular plane systolic excursion. And really, we can't really use this if the patients have some underlying tricuspid valve disease. So that's going to affect the movement of this annular plane. And what you want to do is, if you have a good apical 4-chamber view where you can really appreciate the tricuspid valve and the lateral free wall, you want to use your M mode or motion mode and put that line over the lateral aspect of the tricuspid valve. There's going to be like a little prominence away from the free wall. And it's going to be right next to the tricuspid valve, and that's where you're going to put your M mode. And really what you're going to do is you're going to measure the linear distance traveled between systole and diastole. So it's going to be a height measurement from peak to valley. A normal right ventricle should have a decent amount of movement in this location, and so you'll have 25 to 35 millimeters. In someone with reduced RV function, that value will drop significantly, and it'll be less than 17 millimeters. So these are just two examples of TAPSE calculation. So you can see in both views, you have your apical 4-chamber, right? And you can appreciate this is a little bit more gain and brighter in this view, but you can appreciate the tricuspid valve here, the free wall over here, and then this little prominence right next to the tricuspid valve or right lateral to the tricuspid valve is where you want to put your M mode. And then you want to calculate or look at the distance traveled over time. And so these are going to be the peak and valleys. And really, it's a height measurement. So it's going to be from up here to down here. And so you can see in this example, there's not much movement, right? The peak and valleys look pretty diminished. And when they calculate the distance, it's 14.5 millimeters, which is reduced. In this view, you can appreciate maybe a little bit more movement of the tricuspid annulus, right? And so you can have the peak up here, the valleys down here. And when they calculated it, it was 2.1 or 21 millimeters. And that's sort of an indeterminate value, like anywhere between 18 and 24 is indeterminate, but it would potentially be normal. But you couldn't call it reduced based on this measurement. But definitely less than 17 millimeters is abnormal. And this is something you could do if you do get adequate apical 4-chamber views. So now I just want to run through some examples, and you guys can tell me what view we're looking at here and what you guys think of the right ventricle in terms of size and function.
That's the 4-chamber view, and the right ventricle definitely looks smaller. I mean, looks less than 2/3 of the left ventricle, so it's normal in size, maybe a little bit tiny, I would say, but it depends on how the view was taken. And the function looks good also based on the movement of the tricuspid valve annulus.
Yeah, excellent. Yeah, I mean, you can see it like moves up and down pretty significantly. And yeah, this is the reality of apical 4-chamber views, right? We can't always get ideal views, but you can imagine the free wall is probably over here. So yeah, I agree. It's definitely less than 2/3 the size. So it's probably normal. Definitely not enlarged in size. Excellent. So this is our next example. And so what are the views that we're looking at here, at least?
So the left one is the peristernal long axis, and I believe the right one is that the short axis? Because it looks
it's a little grainy.
Yeah.
Well, don't judge Haley. You know, this is recent port activation. I used her images, but yeah. But yeah, okay. And then what do we think of the size of the right ventricle outflow tract and then the right ventricle in this view?
So on the left one, I mean, it's not the best. I mean, if the right ventricle is very large, you can say that there is enlargement. But but if you think that it may be enlarged, the best one will be the four chamber or the short axis. But it looks, it doesn't look enlarged on that one. On the right one, it's hard to see, but I think. I don't see that there's a flattening of the septum. It looks round.
Correct.
To me.
Yeah,
I don't know.
I agree completely, right? So yeah, the parasternal long view is not going to be a good one to make you think or concern about RV size, because it is just a view of the outflow tract. So it may not be an indicator of what's going on with the rest of the ventricle. So I agree, you can't really comment on it here. But then on this view, yeah, you have the left ventricle here. It is, you know, it's maybe slightly off axis, so it's maybe a little bit more oval in shape rather than a true like circle or donut shape. But the right ventricle does look a little bit bigger than the classic crescent shape you would see. It's heading towards that like half circle shape. But I agree, I don't think there's any septal flattening in this view. And then this is the same patient looking at the apical, or it's actually an apical 5 chamber, right? Because you can kind of see the aortic valve and the aortic outflow tract coming in as well. And what do you guys think?
There, it looks like the right ventricle may be a little bit dilated because it looks like it's almost the size of the left ventricle instead of being less than 2/3. This will be like like you can see the aorta, so it's like the 5 chamber, but it might be upper limits of normal or just mildly dilated.
Yeah. Yeah, I would probably call this mild and maybe even moderately. It's almost equal in size, I agree. And then I do want to just point out, if you can, the RV apex. There is a little bit of increased movement to me of the RV apex moving in and out. So this is potentially someone with McConnell sign as well. So this would be concerning for at least mild to moderate RV enlargement with signs of RV strain. All right. What do we have here?
So you've got the parasternal long on the left, parasternal short on the right.
Yeah.
The RVOT looks pretty big in the parasternal long.
Yeah. So normally, yeah, because normally it almost looks like a little circle up here, but it actually extends all the way towards the apex, which is definitely abnormal. And then the LV cavity size looks very small. The walls look thickened, but that's sort of just an extra finding. And then, yeah, and then what do we think on the parasternal short?
Parasternal short is definitely like a large right ventricle. It's causing the D sign, pushing into the left ventricle.
Absolutely. Yeah. So this is definitely concerning. This is another PERT activation patient. So, and then I think I have, yeah, this is probably the same patient, but unfortunately the apical 4 chamber is not as good, but you have to sort of imagine the free wall being over here, right? So this would be definitely, I would say, at least moderately enlarged, but it's not a view where I would be able to appreciate whether there's McConnell sign or not. All right, what do we, I think this might be the last practice one for the right ventricle, but what do we think about this one? So there's actually a few abnormal findings on all these views. And the excellent people who got these views already labeled them for you. So we have the parasternal long axis on the left, parasternal short axis on the right. And then what are some of the abnormal findings you guys see?
The right ventricle looks severely enlarged. I believe there must be a pleural effusion as well, I think I see.
Okay. And how do we know that?
Because you can, there's also pericardial effusion too, I think.
Excellent.
So if you look very well at the parasternal long axis, you can see on the short axis as well, there is a part where the muscle of the ventricle is separated from another layer. That would be the layers of the pericardium. Then you can see another area that is hypoechogenic. So that's the pleural effusion.
Excellent. Yeah, and normally we like to use the descending aorta to help differentiate the two. You know, it's hard for me to make out the descending aorta. I sort of have to imagine it's somewhere around here. This is probably the coronary sinus, actually, that little dot right there. And then, there's a pericardial effusion, like a small pericardial effusion right here, and then I think a larger pleural effusion below it. I agree. And then this is just probably some atelectatic lung from related to the large pleural effusion. And then I agree with the right ventricle. You can see, right, the right ventricle alpha tract here. And again, like the last example we used, it's extending all the way to the apex and even going past the LV apex, in my opinion. So this is someone that likely has a very enlarged right ventricle. And then what do we think about the function, at least on the short axis?
Of the right ventricle, like it's depressed. I mean, when it's that dilated, like you are expecting it to be like reduced function already. Yeah, but it looks, especially on the short axis, it looks better because it looks like it's contracting a little bit, maybe on the short, but on the long, on the long axis, but on the short axis, it's, I don't know if it's because of my camera, like the internet connection, but it looks like.
Yeah, I mean, it's definitely huge, right? I mean, it looks almost double the size as the left ventricle, right? But the one interesting thing I would just point out is that the left ventricle, though, still looks very circular. And someone with at least like acute RV dysfunction or acute RV strain, I would, especially with the RV being so big, I would normally definitely expect it to be higher pressures than the left. And so I would expect to see some septal bowing and some D'ing of the left ventricle, which we don't see here. So this to me suggests that there's at least some type of chronic process going on. But we do have some other views. So I'll show you guys these other views. So we have a 4-chamber view on the left, and then we have a view of the IVC on the right. And so what do we think? We can focus on the 4-chamber first. So what are some of the abnormal findings you guys see here?
So you don't see that the tricuspid valve is closing.
That's a very important finding, right? Especially in someone who has such enlarged right ventricle and right atrium. You know, the leaflets are not able to fully close up against one another, right? So even though we don't have color on this image, I can tell you guys definitively that this patient has definite tricuspid regurgitation, and it's probably severe because there's a hole that separates the ventricle from the atrium. Yep, absolutely. And then the other thing, we can definitely appreciate that the size of the ventricle is huge compared to the left side, right? And then the apex, right? What's taking up the majority of the apex? It's going to be mainly the right ventricle, which again is very abnormal. So this is someone who has a severe enlarged right ventricle, also severely enlarged right atrium. This whole thing is the right atrium, and then severe tricuspid regurg. And then the IVC, what do you guys think?
Huge.
Dilated with no respiratory variation.
Absolutely. And what else can you guys like see? What other vessels?
Hepatic veins.
Yeah, and it's extremely, even the hepatic veins are very dilated. You can like see it tracking all the way up here. So this is someone, who's very overloaded. I think when they did the formal echo, the IVC was 3.4 centimeters and non-collapsible. So, I mean, you can really appreciate how big it is right here. Yeah, so this is excellent. And this was a patient that, the ultrasound wasn't interested. So you guys can get excellent views and really make interesting diagnoses. All right. Any questions about RV size, function? We're just going to spend maybe now 10 minutes going over DVT studies. And feel free to interrupt me whenever something doesn't make sense. So why do we do bedside DVT studies? Well, it allows for rapid assessment in patients who may be too unstable to go for more comprehensive testing, like formal DVT studies and CT angios, things like that. The main indication for when we would do it at the bedside, especially in the critical care setting, is if we're concerned for DVT-PE, if a patient has undifferentiated shock, if they're hypoxic but their chest X-ray is clear, right? Or if we did the bedside echo and they have RV strain. That being said, the whole design behind POCUS DVT is that we want to be as quick as possible and have the highest yield as possible in the quickest amount of time. So really, for purposes of the bedside DVT study, we're just looking at the common femoral branch points, and then we go down to the popliteal vein. So we don't actually do the entire extent of femoral veins. So if you order a formal DVT study, they'll actually start up by the inguinal ligament, and they'll track the femoral vein all the way down to below the calf, or all the way down to the mid calf. But obviously that's time consuming. So what we do is we just look at the femoral branch points, which are the most common places for DVTs to form. And then we have a single view in the popliteal vein. But because it is a limited study, we are missing about 10% of true DVTs. So if, let's say, you do a bedside study and it doesn't look like there's a DVT, but you're still worried for one, you definitely absolutely need to get additional studies or a formal study when one is available. So anatomy is important. So this is just showing the common branches. So you want to start when you're doing your bedside DVT study at the right below the level of the inguinal ligament. And so the first vessels that you'll see are the common femoral artery and common femoral vein. And you have to remember your naval mnemonic, right? So if you think about what's more lateral to the patient, right? It's nerve, artery, vein, and then lymph node, right? So on the right side, the artery will be lateral to the patient, so to the left of the screen. And then on the left side, the artery will be to the right of the screen, which is the lateral part of the patient. So once you have your common femoral artery and vein, the first thing that comes off is the greater saphenous vein. And that's going to go medial. So it's on the right side, it's going to come off usually around 1 or 2 o'clock. And then it's going to be around 10 or 11 o'clock on the left side. And so anytime you see branch points, that's a very common area where you would see clots form. So you want to always compress there. And then the next thing to bifurcate will be the artery will bifurcate into the superficial femoral artery and the deep femoral artery. And then you'll often see a vein bisecting those two, and that's called the lateral perforator vein. And this is what we have previously described as like the Mickey Mouse sign, because you have your Mickey Mouse ears and Mickey Mouse face here. And so this is another area where clots can form. And then the last thing to branch off in the common femoral area is the femoral vein will become the femoral vein and deep femoral vein. And once you get to this point where you can make out 4 vessels and you compress all the way down here, then you could just jump down to your popliteal, and you have your popliteal vein above the popliteal artery. In terms of getting good views, appropriate technique and positioning is really important, right? So in order to get a good DVT study, you want the patient to be completely supine, have their stomach out of the way, and have their legs in a frog-like position. So really the knees should be slightly bent outward with the legs externally rotated. You're going to be using your vascular probe because for the most part, these veins or arteries and veins are superficial structures. And so vascular probe has the best image resolution at these depths. And then for the entire DVT study, the marker should be at 9 o'clock. So it should be to the left of the person getting the images. So hold the mark at 9 o'clock. And so the marker will be to the right of the patient, and that'll correspond to the left side of the screen. And that'll help orient you. So that way, whether you're doing a right side of DVT or left side of DVT, you can figure out the anatomy. So if you're using proper technique, the artery will be on the left of the screen for the right leg, and it'll be to the right of the screen on the left leg. And you want to make sure you assess at these 3 groin sites and 1 popliteal fossa. And when you're in the groin, you want to go down every 10 centimeter you go down, you should compress. And really, you don't need to compress so hard that the artery gets compressed. If the artery is getting compressed, then that means you probably are putting a little too much pressure on it. And you certainly don't want to compress too hard if there actually is a clot there, because then you could potentially move the clot upward and cause a whole array of issues. So you should just compress gently enough to actually appreciate the lack of compressibility of the vein. So when you're using the appropriate technique, you start at the inguinal ligament, first thing you need to do is identify the common femoral artery and vein using your naval mnemonic to help identify the structures and compressing every 1 centimeter. And really, you need to adjust your depth as needed to ensure that the main vessels of interest are in this exact center of the screen. Branch points are going to be the most common areas for clots to form just because of the shear stress at those levels. And so you have the greater saphenous vein coming up first, the common femoral artery bifurcates next, and then the femoral vein bifurcates after that. And then with the popliteal vasculature, the popliteal vein is extremely compressible and collapsible under normal circumstances. So you want to use as little compression as possible when you get to that point. So these are just ways we appreciate it, whether there's a clot, right? So the main ways is what you hope to see is direct visualization, right? So you may see a hyperechoic object within the vessel. So you can appreciate a hyperechoic object right here. And then this is going to be more towards the side of the vessel here, right? And then this is a longitudinal view, but you can really make out the clot here. A lot of times, though, especially in the acute setting, the clot might not be that hyperechoic. So really the main way we identify or diagnose DVTs at the bedside is just showing a lack of compressibility. So a lack of compressibility is going to be the most common finding that you have, and that'll indicate the presence of a clot, even if you can't directly visualize one. And that being said, you can also add color potentially to your view as well if you're not sure you see a clot. And then so this is just highlighting that there's blood flow here, but then there's a clot above it that's partially obstructing the vein. Questions about that? So some of the important things to be aware of, especially when you're in the groin area, right, is to worry about DVT mimickers and smoke within a vessel. So smoke within a vessel is going to be especially common in patients who have cardiogenic shock where there's a low flow state. This doesn't necessarily mean a clot on its own. You'd have to try and use some of the other findings I mentioned in the previous slide to really diagnose this. And then as opposed to acute thrombi, which are in the center of the vein, usually chronic thrombi are going to be more adherent to the wall. They're getting, the body's starting to try and eliminate it. And so they may tend to be a little bit more hyperechoic as well. And then these three things can often mimic clots, so you always have to be wary of them as well when you're scanning. So the most common thing that's misdiagnosed as a clot is a lymph node. And really the ways around whether you see lymph node hematoma or cysts around the vessel is to track up and down, right? A vessel will persist in your view throughout as you track up and down, whereas a lymph node, hematoma, cysts, they'll come and go. So that's how you can best decide whether or not what you're seeing there is a clot or not. So I just want to run through a couple of examples in the few minutes we have left.
Oh, sorry. Can you repeat the part of the lymph node, like how we differentiate the lymph nodes from the clot?
Yeah, so the lymph node is only going to be, essentially a couple centimeters long, right? So it's going to be a little bit more oval in shape as opposed to the vessels. It's going to be more thin-walled. And so really, if you think you see a clot, you always want to track it up and down a few centimeters. If it's within a vessel, the vessel will stay in your image, right? Because the vessel tracks all the way down the leg, whereas a lymph node will only be a couple centimeters long at most. So if you track up and down and your image of the clot disappears, then that's probably a lymph node. We may or may not have an example of that coming up. All right, so what do we have here?
So it's the common femoral artery and the common femoral vein more medial to it.
Yep.
And I think when the operator is compressing, the vein is not compressing.
Yep.
And there also might be a hyperechogenic structure inside of it.
Excellent. Yep. Yeah. So when you compress, you can really appreciate the hyperechoic structure because the depth decreases, right? So yeah, I agree. So this is the common femoral artery right here. You can see it's pulsatile. It's smaller and more circular in shape with a thicker, brighter wall. And then the vein is right medial and slightly below it. And then, yeah, when you compress, that doesn't actually fully compress. You can see the artery is even compressing more than the vein is. And then when it is compressed, you can appreciate there's a hyperechoic structure. Now, is this on the right or the left? Assuming a appropriate technique.
So I would say the mark is the green thing that's at the right of the screen, right?
Correct. Yeah.
The mark is where you have the, oh, so if that's the right, then I guess
Correct.
it'd be on the right femoral vein.
Exactly. Yeah. So this is the marker is going to be the user's left hand or user's left side, so the patient's right side. And so on the right side, the artery is going to be lateral or to the left of the vein. Yep. So this is going to be a right common femoral DVT. Perfect. And this is excellent views because it looks like it was Dr. Salonia. So. All right. Then what do we have here?
That's the Mickey Mouse sign.
Yeah, excellent. So you have your superficial femoral artery here, and then this is probably your deep femoral artery here, and then you have your vein right here in the center. And you see the arteries on the opposite side as the last clip, right? So assuming proper technique, this is going to be in the left common femoral vein, right? And then what are we seeing within the vein here?
That looks like a valve.
So this is actually, so a valve will be very thin. It'll be like literally just a very like thin, slender line. Whereas like this, there's something thicker here. It's taking up a good amount of the vein. The one thing I will say is the person getting these images is definitely compressing too hard, and it's making me a little nervous because the arteries are getting completely compressed, and there is something here. So if you compress too hard, you might dislodge whatever's here right now. But this is another example of a DVT actually. I didn't include any pictures of valves in this presentation, but it is a fairly common finding. The main area where you tend to see the valve is going to be immediately off the greater saphenous. There's often a valve there. What do we think about here?
Like there are two DVTs, but I'm not sure where.
So this is going to be your DVT mimicker. So this is actually I think part of the issue is right. If you can't identify the anatomy, then something's off, right? So I think this is maybe some type of superficial artery, maybe that's in the center. But these right here are actually examples of lymph nodes, and you can tell they're lymph nodes as opposed to veins because you see how the walls are kind of irregular, and the clot mimicker that's in the center is really very bright. And taking up like a 90% of the structure. And as we're fanning in and out, you can see the diameter of the structure disappears and expands and disappears. So this is something that's only a couple centimeters long. So these are examples of 2 lymph nodes actually. I will say, when you're doing especially femoral DVTs and you're trying to find the common femoral, you do tend to have to go maybe slightly deeper than what this view is. And so that's another maybe tell that these are maybe inguinal lymph nodes that are just maybe slightly larger than normal. But yeah, so this would be an example of a DVT mimicker. The other thing you can do potentially if you're not sure is you can add color, right? And so if these were true DVTs, you would still be able to see some flow around it. Whereas if there was no flow, that would be another indicator that they were probably lymph nodes. And what do you guys think here? So on the left, right, you have your artery to the right of the screen, right? And then you have your vein in the center. And then you can kind of see maybe the saphenous veins coming off in part of the clip. Yep, you have to kind of take my word for it, I think. And then right in the center of the vein, there's a hyperechoic structure that prevents the vein from getting truly compressed. So this would be a common femoral DVT. And we're on the artery is to the right of the screen. So this is on the left side. And again, this is as we're tracking down on the patient. This is where the artery bifurcates. You have your superficial femoral artery and deep femoral artery right here. This is kind of a Mickey Mouse sign, and then your common femoral vein here. And you can see the clot really takes over most of the structure of the vein. And then I think I have maybe one final example.
Sorry, Dr. Rothman, can you repeat the rationale why you know that it's on the left side?
Yeah, so if we're assuming proper technique, right, that you see how the artery is to the right of the screen.
Yeah.
So the on the patient's body, the artery is always going to be, it should always be lateral to the vein. So if the dot is pointing to the patient's right, that means the left of the screen is medial and the right of the screen is lateral.
Oh yeah, okay, got it. Thank you.
Yep. No problem. Just for sake of time, since we're just about out, so this is I think the last image. And what do you guys think?
So this looks like another left common femoral with the saphenous coming in at the end.
Yep.
The artery on the right of the screen, and it's non-compressible. So left common femoral DVT.
Yeah, and really, it's a little grainy, I think, right now, but you can kind of see there's something bright in like the whole saphenous and even up towards some other further branch points. So I think this is an pretty extensive DVT, but definitely the fact that it's not compressible would make me worried for a clot. And I think the saphenous vein looks a little bit more dilated than what I would expect as well, to suggest that maybe there's some blockage of flow. So yeah, this is definitely a large left common femoral DVT. Great. All right, any final questions before I ask you guys to please do this post-test?
Do you mind just repeating the TAPSE? Does it measure the distance of the lateral tricuspid angulus or the distance of what exactly?
Yeah, so you're looking at the prominence of the annulus to the right, directly lateral to the tricuspid valve leaflets. And really you're measuring how much that's moving up and down during systole and diastole. So it's moving up towards the probe and away from the probe as the ventricle is contracting, and you're measuring that height, that movement up and down.
Oh, got it, thank you.
Yep, no problem. I can type in the chat just so you guys have, if you guys can't use the link or the QR code here, just so everyone has it.